Okay, well, welcome everybody, and thanks for joining. We're going to start now. So my name is Chris Morrow, the director of the Island Medical Program Physician Education Program, and we're super excited to have you here for the second of our dermatology series on actinic keratoses and keratinocyte carcinomas. And I'm going to introduce Jean in a moment. I'm going to start off with a land acknowledgement. I'm currently actually in Kelowna at a faculty development event, so I'm amazed by the amazing environment here of the Syilx Okanagan Nation. And I encourage everybody to think of the land they're on and how we impact it. But also, as I reflected at our first session, it's interesting to think how Indigenous peoples approach to dermatology. And although they have a bit of a slightly lower incidence of some of the skin cancers like melanoma, due to barriers in healthcare, they also do end up presenting with some significant skin cancer issues. And interestingly, here in the Okanagan, the Syilx people used bitterroot for various skin ailments for thousands of years. And they also as a cleanser or a clearing agent. So even back then, people were treating their skin with a cleansing and clearing agent. So it's interesting to think about. Just before I introduce Jean, Leah, did you want to talk about Slido real quick?
Sure. Just everyone, I'm going to put a link in the chat to our session Slido, and feel free to put any questions you have throughout the talk into that Slido, and in the last 15 minutes or so of the presentation, Jean will answer them. So putting that in right now.
Thanks, Leah. So I'm super happy to introduce you to Jean. This is the most passionate dermatologist, family doctor I've met, with a super conscientious approach to things. Jean is a family medicine specialist who now has a practice focused in skin cancer. He's based in Nanaimo, and he's the co-director of Skin Care West, which is an 8-physician clinic that serves dermatology referral for the Central Island. He has a master's degree in skin cancer medicine at the University of Queensland, and he's a clinical assistant professor with UBC, Department of Family Practice, and also an affiliate member in the Division of Medical Sciences. He also was the medical director for Health Cert International, which is a company that did the first Canadian advanced skin cancer procedures course. And we've also been lucky enough to have him run in our last 2 conferences at the Island Medical Conference, a skills day, where he's basically built and created a great experience with biopsy. He's also served on planning committees for CME programs developed by the Melanoma Network of Canada and MD Briefcase. And he's also a speaker for skin cancer at the annual Conference of Primary Care Dermatology Society of Canada. He currently provides comprehensive skincare, cancer skincare, including diagnosis using microscopy and imaging, and he does both surgical and non-surgical treatment. His practice includes pigmented lesion assessment, surveillance related to melanoma, and the augmentation of high-risk skin cancer patients, such as management, not augmentation, of high-risk skin cancer patients, such as organ transplant recipients. And yeah, as I mentioned, Skincare West is, it's got dermatologists and family docs, and they're a very collaborative environment and well-respected and super efficient in the Mid-Island. So I have nothing else to add to that introduction, except that he's a wonderful teacher. And take it away, Jean.
Thank you for that introduction, Chris, and thank you to IMP's Physician Education Program for organizing the Island Dermatology Series. I appreciate the opportunity to speak to you tonight about keratinocyte carcinoma. Despite being the most common form of cancer in humans, its impact on patients is often underappreciated. The number and breadth of different providers who have registered for tonight's session speaks to the relevance of these tumors in many different areas of care. I hope you find this presentation useful, and I look forward to your questions. Hopefully I can make this move. There we go. These are my disclosures. I don't have any conflicts of interest related to the material we'll be covering today. Come on. No, sorry guys, I'm having a, there. These are tonight's objectives. We'll start with some key points related to keratinocyte biology. Then we'll focus on basal cell carcinoma and its three major subtypes. After that, we'll turn our attention to actinic keratosis and lesions within the squamous cell carcinoma spectrum. I'm sure many of you signed up for this talk hoping for some embryology, so let's start there. Humans are triploblastic animals. In an early stage of embryology, the blastula invaginates to form a gastrula with three distinct layers: the ectoderm, endoderm, and an in-between layer called the mesenchyme or the mesoderm. All human tissues are derived from these three layers. The outer ectoderm goes on to form three types of cells: keratinocytes, neurons, and melanocytes. Keratinocytes make up the bulk of the epidermis, the outer layer of the skin. The skin's deeper layers, the dermis and the subcutis, are derived from the mesoderm, which is responsible for fibrocytes, adipocytes, muscle, endothelial, and blood cells. After gastrulation, the ectoderm goes through another critical transformation. Along the dorsal surface of the embryo, it forms a neural fold and groove, and then the neural crest and tube. The cells within the neural tube go on to form neurons and the well-defined structures of the nervous system. Melanocytes are derived from the neural crest and follow a different developmental pathway. Instead of forming a distinct organ, they migrate from the crest to other areas. They eventually settle in a broad range of structures, including the skin, eye, inner ear, brain, and gut. In addition to keratinocytes, ectodermal cells that stay on the surface of the embryo form the bulk of structures that project down from the epidermis, such as hair follicles, sebaceous glands, and sweat glands. The mixed ectodermal and mesodermal origin of our skin leads to a distinct structure to its layers. The outer epidermis is highly cellular. It's packed with rapidly dividing keratinocytes. The deeper and much thicker dermis is slower growing and fibrous. It consists mostly of collagen and elastin, vascular structures, and nerve endings. Beneath the dermis is the subcutis, which is predominantly adipose tissue. I'll be showing images of histology slides throughout this presentation. This is normal hematoxylin eosin stained skin. The fluffy upper layer is keratin. If this layer becomes abnormally thick, it is referred to as keratosis. The dark purple layer is the epidermis. Keratinocytes and related cells readily pick up hematoxylin, so you can use its purple color to also identify hair follicles and glands projecting down into the dermis. The dermis is mostly red from eosin staining of collagen and elastin. Adipocytes in the subcutis don't pick up either stain. Now let's pan in on the epidermis. At the top is a thick but normal appearing keratin layer, likely because this sample was taken from a heavily cornified area of skin, maybe the sole of the foot. In the middle is the highly cellular epidermis. At the bottom is the predominantly fibrous dermis. The two upward projections are dermal papillae. The basement membrane lies between the epidermis and the dermis. It binds the two layers together and also acts as a substantial mechanical barrier to deeper invasion by epidermal malignancies. Above the basement membrane is a single cell thick layer of keratinocytes called the stratum basale. These cells are special in that they are non-keratinizing. Their purpose is to remain in place, multiply, and continuously send new cells into the upper layers. The keratinocytes in the layers above the stratum basale are keratinizing. They do not divide, but instead gradually migrate upwards, lose intracellular structures, flatten, and become new keratin. The keratin layer on the skin surface serves as a protective barrier against the external environment, but it can't completely filter out ultraviolet radiation from the sun. That leaves cells in the epidermis at risk for UV-induced mutations. Melanocytes form melanin, which is the pigment that determines hair and skin color, but it's also highly effective at absorbing UV. During their migration out from the neural crest, they travel to all areas of skin, spreading out along the basal layer in a 1:10 ratio to keratinocytes. Black arrows in this image point to melanocytes in hematoxyl and eosin-stained skin. Here they are again, but after processing with a melanocyte-specific stain. Each melanocyte interacts with 30 to 40 keratinocytes in the layers above it through dendritic projections. The dendrites carry melanin within melanosomes up to the keratinocytes, where it is laid down above the nucleus in protective supranuclear caps. The type of melanin produced and the size of melanosomes it's packaged into is what determines skin color and tanning ability. Those two factors together are often combined into what's referred to as a skin phototype. Risk for keratinocyte cancer is highly correlated to skin phototype. Darker skin equates to better UV protection and therefore lower risk. Despite being the centers of melanin production, melanocytes can develop UV-induced mutations leading to malignant proliferation. Melanocyte-derived tumors can metastasize widely, even when exceedingly small. They also often have a characteristic black or brown appearance. This has historically led to the classification of skin cancer into melanoma and not melanoma. Unfortunately, this approach leads to confusion at times for both patients and clinicians. Patients may only remember the word melanoma when receiving their diagnosis, given the often strong emotional reactions to the term. This can lead them to misinterpret the nature and severity of their cancer and to later report having had a melanoma as part of their medical history. Not infrequently, clinicians and medical reference sources have tended to incorrectly equate non-melanoma skin cancer with only basal and squamous cell cancer. In actuality, the term encompasses a very broad and in many ways unrelated group of tumors. The most functional way of grouping skin cancer other than melanoma, based on biology and clinical implications, is keratinocyte carcinomas, adnexal carcinomas, a complex group of rare tumors derived from hair and glands, Merkel cell carcinoma, a rare sensory cell-derived tumor that has the highest mortality rate of all skin cancers, dermally derived sarcomas, and cutaneous lymphomas. A few conditions don't fit well in any category. Keratinocyte carcinomas fall into two groups that are often distinguishable on a clinical basis. Basal cell carcinomas form tumors that are not associated with much keratin scale, since they are derived from non-keratinizing cells at the bottom of the epidermis. They can be classified into three subtypes with specific implications for diagnosis and treatment: superficial multifocal, nodular, and infiltrative. Squamous cell-derived tumors are usually associated with the presence of scale because they develop from keratinizing cells higher in the epidermis. They can also be classified into three groups: premalignant actinic keratosis, lesions of uncertain or low malignant potential, including in situ squamous cell carcinoma and keratoid canthoma, and true invasive squamous cell cancer. Basal cell cancer is the most common human cancer and accounts for 1/3 of all annual cancer diagnoses in Canada. It affects 50 to 60,000 Canadians per year. Lifetime risk is about 1 in 8 for the entire population, but amongst Caucasian Canadians, it is 1 in 3 for males and 1 in 4 for females. Individuals with a history of BCC are at very high risk for developing additional lesions. They are also 3 times as likely to develop melanoma. BCC occurs predominantly in older individuals and those with lighter skin phototypes. Risk factors include high sun exposure, tanning bed use, ionizing radiation, including radiotherapy, particularly at a young age, arsenic exposure, and immunosuppression. Certain occupations, such as outdoor workers, that are at increased risk. BCC can also occur at increased frequency in certain rare genetic skin disorders, such as basal cell nevus syndrome. As opposed to cumulative sun exposure, basal cell carcinoma is most strongly associated with severe sunburns, particularly in childhood. Tumors present many decades after the inciting events, often in areas that are not typically associated with high sun exposure in adults. Superficial basal cell carcinoma is flat and pink or red in its early stages. It can be difficult to differentiate from an inflammatory skin condition, so sometimes leading to treatment with a topical steroid. These lesions gradually increase in size over months to years. They tend to remain shallow, but can develop areas of deeper invasion. Some reference sources use the qualifier multicentric instead of multifocal. Many sources don't include either term. That leads to an underappreciation of this subtype's potential for subclinical spread beyond visible margins, which can lead to recurrence after excision. Superficial BCC can also recur after non-surgical treatment due to focal areas of deeper extension along hair follicles. These lesions, along with the one from the previous slide, are from the same patient. The shoulders, chest, and back are common locations for superficial BCC, since those sites are often sunburned in childhood. Erythema is a feature of all these lesions. Superficial BCC often presents with a more subtle pearly pink color, but you can get it to stand out bright red by wiping the skin with alcohol or chlorhexidine soaked gauze. These lesions don't have much surface scale. Compare the benign seborrheic keratoses on the patient's back in the image on the far left to his basal cell cancers. Many sources describe superficial BCC as scaly, but scale is actually not an overly prominent feature of any BCC variant. Under magnification, small ulcerations are visible in all these lesions. In normal skin, keratinocytes have strong attachment points to each other and to the basement membrane, called desmosomes. Keratinocyte carcinomas, particularly basal cell cancer, are prone to ulceration and bleeding because they form abnormal desmosomes, which provide weak cell-to-cell adhesion. Here's a slightly larger superficial BCC that is starting to develop multiple small peripheral areas of nodularity. Under magnification, these thicker areas have very crisp, small caliber branching blood vessels. That finding is highly predictive of basal cell carcinoma. When the patient came in for treatment, the lesion contained several new ulcerations. This is a very common pattern with basal cell cancers. They are easily traumatized, bleed, appear to improve, and then repeat the cycle. Patients often present complaining of a wound that almost, but never quite completely heals. Here are two more examples. Again, note the presence of erythema, absence of prominent scale, and multiple small ulcerations. Some areas within these lesions may look like scale, but it's crust. Scale is keratin and often fairly adherent. Crust is dried serosanguinous exudate and easily picked or wiped off. Finally, here is an example of a pigmented variant of superficial BCC. These are most often seen in individuals with darker skin phototypes. Erythema, absence of prominent scale, and multiple small ulcerations remain dominant features. The pigment in these lesions is melanin, supplied by normal melanocytes in the surrounding skin. Here is a histologic image of superficial BCC with normal skin on the left. Note the multifocal nature of the lesion. It has many downward areas of budding off the bottom of the epidermis, interspersed with normal appearing skin. It's also very shallow, with plenty of healthy dermis beneath it. Nodular BCC presents as a raised papule or plaque with a translucent telangiectatic border. It tends to be sharply defined and often develops central areas of ulceration. The lesion in these images is a typical example. The yellow-white area in its center is not scale, but a crust on top of an underlying ulcer. Nodular BCC gradually increases in size and can become deeply invasive, including into cartilage and bone. Here are two additional examples from the same patient. Note the overlap with superficial BCC in terms of erythema, absence of prominent scale, and presence of ulceration. But these lesions are centrally raised and they have well-demarcated borders. On magnification, the one on the left has a large central ulcer, and the one on the right has multiple small areas of crust. If you wipe the lesion on the right with an alcohol swab, the crusts would lift off, revealing multiple small bleeding microulcerations. Here is another example. Erythematous, raised, I think your screen, there. Erythematous, raised, sharply demarcated, centrally ulcerated papule without much surface scale. Nodular BCC is often described as pearly due to its translucent borders, which can reflect a bit of light. If you look carefully, you can see that in the image on the right. There we go. Here's a lesion that has grown quite large without ulcerating. This growth pattern is sometimes referred to as nodulocystic BCC. Under magnification, you can see many crisp, small caliber branching blood vessels, which helps to confirm the diagnosis. Here are some pigmented variants. Without dermoscopy, these can be very difficult to differentiate from melanocytic lesions. The patient on the right has a history of melanoma, and he also has many benign nevi. The lesion on his back is an outlier with some worrisome clinical features. It might just be an atypical mole, but it could also be a melanoma or a melanoma metastasis. Fortunately, under magnification, it has classic features for BCC. The lesion on the left is much more difficult to diagnose, even using a dermatoscope. The only way to be certain of its nature is biopsy. Here is a histologic image of nodular BCC on the right, with normal skin on the left. Note how the lesion is quite raised and has very sharply demarcated borders. Infiltrative BCC is a less common but more deeply invasive subtype. It can become very large before it is clinically apparent. Early lesions present as poorly circumscribed, pale, flat, or slightly atrophic papules or plaques. This subtype has several distinct growth patterns with different manifestations on histology. Pathology reports sometimes use other terms such as morpheiform, sclerosing, desmoplastic, and micronodular. All these variants share a common feature, which is substantial subclinical extension into the surrounding dermis. Infiltrative BCC has a higher rate of recurrence after treatment. It is generally best managed through surgical excision with wide margins or Mohs micrographic surgery. The infiltrative subtype can be very subtle. It often presents like a scar, which appears to be increasing slowly in size. This is a patient with a nodular BCC on her nose, which I treated with curettage. 3 months later, when I brought her back for reassessment, I spotted an infiltrative BCC on her cheek that I had missed on her previous examination. Here is the lesion with its borders inked prior to biopsy, and here it is under magnification. Note the crisp, small caliber branching vessels typical for BCC, but on a whitish, almost scar-like background, as opposed to the erythema found in superficial and nodular variants. Here is a histologic image of an infiltrative BCC on the right with normal skin on the left. This lesion is very poorly circumscribed. It has a deceptively normal appearing epidermis on its surface, yet it invades deeply into the dermis in thin purple cords. I'll bring back nodular BCC on the left for comparison. Now let's look at micronodular BCC on the right. The use of the word nodular in its title often causes confusion. Micronodular BCC is a histologic variant of infiltrative BCC that grows in many small nodules instead of thin cords. BCC is the most common cancer in humans, so there are many options when it comes to diagnosis and treatment. Partly it depends on lesional factors such as location, size, thickness, and clinical features. It depends on patient factors such as age and comorbidities. It depends on the provider, particularly their use of dermoscopy and comfort with surgical procedures. There are patient preferences to consider, especially their bias towards cure versus the cosmetic impact of treatment. Finally, treatment decisions are also influenced by the emotional and psychological response of both provider and patient to the diagnosis of carcinoma. The term carcinoma is used for malignant tumors of either ectodermal or endodermal origin. It does not indicate anything about their metastatic potential. The exact frequency of metastatic BCC is unknown due to lack of registry data, but it is exceedingly rare. There were only 364 cases reported in the world's literature between 1894 and 2011. Metastatic disease in lesions that are 1 centimeter or smaller is anecdotal. Despite this, when faced with a diagnosis that includes the term carcinoma, many patients will accept and providers will perform invasive and sometimes disfiguring procedures to increase the probability of cure. Some of you will be familiar with dermatoscopes, but for those who are not, they are handheld microscopes which allow you to see structures a short distance into the skin that would not otherwise be visible. They are readily available, have broad utility in the diagnosis of skin conditions, and can be effectively incorporated into clinical practice with very limited training. Use of a dermatoscope significantly expands the range of clinical features available for making treatment decisions. This is the infiltrative BCC we looked at earlier. On naked eye examination, it doesn't look like much other than maybe a subtle scar. Under a dermatoscope, the diagnosis becomes clear and you can proceed to biopsy with confidence. In regard to the type of biopsy, there are two major approaches from which to choose. A shave-based biopsy provides a sample that includes the epidermis and a superficial portion of the dermis. Since basal cell carcinoma is an epidermal lesion, a shave will be adequate to confirm the diagnosis in most cases, and it has the advantage of leaving the dermis below the lesion intact. If a lesion appears clinically low risk, and you are planning on using a non-surgical treatment, the best biopsy is usually a shave. The alternative is a deeper incisional biopsy, which is most commonly done with a punch. This takes longer to perform and requires more equipment, but it allows you to sample a deeper portion of the lesion. Punches are usually the best choice for clinically high-risk lesions, particularly infiltrative BCC. The Canadian Dermatological Association issued guidelines for the management of basal cell carcinoma in 2015. Here are their risk stratification recommendations. Nodular and superficial subtypes are low risk on most body areas up to a fairly large size. Variants of infiltrative BCC, large tumors, and tumors in a limited number of anatomically complex locations are high risk. Here are their treatment guidelines. Excision with fixed margins and curettage-based treatment are considered standard options for low-risk lesions, with imiquimod, cryosurgery, and PDT as potential alternatives in select cases. High-risk lesions should be preferentially treated with Mohs or standard excision, but with wider margins, with radiotherapy as the alternative in non-surgical candidates. I'm going to quickly go through diagnostic and treatment decisions for some of the patients I showed earlier. I'm happy to go into further detail during the Q&A after the talk. Clinically classic superficial BCC, shave biopsy followed immediately by treatment with electrodesiccation and curettage. Large recurrent superficial BCC in an elderly gentleman. He did not want any form of extensive surgery. Shave biopsy followed by treatment with electrodesiccation and curettage. Here he is immediately after the procedure. This is about 3 months later, well healed with no clinical or dermatoscopic signs of persistent carcinoma. Elderly woman with a large superficial BCC on her chin. If you look closely, you'll see she also has multiple sites of involvement around her lips. Multiple small shave biopsies followed by 6 weeks of imiquimod. Here she is during treatment, looking a little worse due to the expected inflammatory response. Here she is soon after finishing treatment, erythema starting to clear, and no more crusting or ulcerations. Clinically classic nodular BCC, excision with a small clinical margin. Here is the patient whose infiltrative BCC I initially missed. Shave biopsy followed immediately by curettage without electrodesiccation for the nodular BCC on her nose. Later, I brought her back for a punch biopsy of the lesion on her cheek, followed by a referral to plastics. 2 lesions in the same anatomic area. The one on the left had a low-risk appearance consistent with nodular BCC. Shave biopsy followed by referral to plastics. The one on the right was clinically suspect for infiltrative BCC. Punch biopsy followed by a referral to Mohs. This patient had many basal cell carcinomas. The larger, more nodular lesion on her shoulder was excised. The others were shaved, followed immediately by electrodesiccation and curettage. I included this case for this image, showing the final cosmetic outcome of each approach. Cutaneous squamous cell carcinoma is the second most common malignancy in humans. Most sources quote a 1:4 ratio to basal cell cancer, but incidence is increasing. Lifetime risk for the general Canadian population is about 1 in 20, but it is higher for older individuals, males, and those with a lighter skin phototype. Excess UV exposure is the most important risk, but SCC is multifactorial. It can be induced by chronic inflammatory skin conditions such as burns, non-healing ulcers, and lichen planus. There is a role for the human papillomavirus when it occurs in non-sun exposed body areas. It is more frequent and more aggressive in the context of immunosuppression, particularly in organ transplant recipients. It is associated with exposure to radiation, polycyclic hydrocarbons, and arsenic. It is more common in certain genetic skin syndromes such as xeroderma pigmentosum. As opposed to sunburns, SCC is associated with chronic lower-grade sun exposure. That leads to increased occupational risk in outdoor workers, those who have served abroad in the military, or have done overseas work or travel for other reasons. It occurs most often in areas of high cumulative sun exposure and has a clear progression spectrum from premalignant actinic keratosis to invasive disease. Actinic keratoses are erythematous papules with variable but sometimes quite thick, gritty surface scale. They predictably occur in areas of maximal sun exposure, such as the face, scalp, and extremities. They are premalignant because they come and go. Less than 1% will progress to invasive squamous cell carcinoma. Here are some examples on facial areas. These are examples on the temples and scalp. Here are some examples on the upper extremities. Differentiating between superficial basal cell carcinoma and actinic keratosis can be difficult at times. The main clues are the presence of ulcerations with or without loose overlying crust in BCC versus gritty adherent scale and the absence of ulcerations in AK. Dermoscopy can also be very helpful. Under magnification, actinic keratosis presents as white circles with surrounding erythema, or what's sometimes referred to as a strawberry pattern. For decades, our standard model of actinic keratosis progression was upward growth first, gradually leading to full thickness epidermal involvement, and then eventually downward growth with invasion through the basement membrane. That model led to a focus on treating thicker, more hyperkeratotic lesions, since they had the highest level of epidermal involvement on histology and were presumed to be the highest risk for progression to SCC. In 2015, the publication of this study raised serious doubts about the assumptions in the standard model. It found that histologically mild actinic keratosis, with changes limited to the deeper epidermis, was the most common finding associated with squamous cell cancer. Early in 2018, a new method for classifying the histology of AK was proposed based on basal growth patterns instead of upward growth into the epidermis. It's called the PRO system for proliferative. The dotted line in this photomicrograph indicates the separation point between the newer PRO and older grading systems. The solid white line highlights downward projections referred to as papillary sprouting, which indicate a grade 3 lesion. This image shows examples of different grades of upward and downward growth. A lesion can consist predominantly of downward growth, upward growth, or a combination of both. In 2019, this study provided definitive evidence that downward growth is reliably associated with progression to SCC, but that upward growth is not. It was a retrospective slide review with 307 primary invasive squamous cell carcinomas. In the adjacent epidermis, the PRO grade of AKs increased consistently from 1 to 3, while grading based on upward growth was inversely related. Over 50% of the actinic keratoses next to the squamous cell carcinomas were what we have historically considered as mild. Only 6.8% were severe. In the overlying epidermis, only upward growth could be assessed, and there was no association between AK severity and the presence of SCC. These findings suggest a new model in which there are two manifestations of AK. The first is upward growth into the epidermis, which produces visible keratosis but has a low risk of progression. The second is downward growth into the dermis, which doesn't lead to much keratosis but is associated with a higher risk of progression. For any given lesion, clinical appearance is not predictive of the underlying histology or the risk of progression. The new model fits well with a growing body of evidence that field-applied treatments reduce the risk of developing SCC, while lesion-directed treatments on their own do not. If a patient has a limited number of lesions, a modality like cryosurgery is a good treatment option, since it is quick and effective. Patients with extensive actinic keratosis need field therapy. The three most common field treatments for AK are variations of 5-FU, imicomod, and photodynamic therapy. All of them have roughly similar clearance rates and clinical effects. This is day one for a patient who will be applying a 4-day course of Efudex with calcipotriol to his face. From a clinical perspective, it's not obvious that he has much actinic damage. This is day 7 around the, sorry, one sec. Let's go back. It's just a little slow. Okay, this is day 7 around the peak effect of the treatment. Although 5-FU is best known as a chemotherapeutic, its mechanism of action when combined with calcipotriol is through immunomodulation. For that reason, the inflammatory response often continues to increase for several days after the patient has finished applying the compound. After peaking, the inflammatory response settles quickly. This is the patient on day 13. Risk reduction for developing squamous cell carcinoma in the first year post-treatment is substantial, but it returns to baseline within 3 to 4 years. Most patients will need to repeat treatment every few years to maintain the effect. In situ squamous cell carcinoma falls somewhere between actinic keratosis, which is clearly premalignant, and true invasive squamous cell cancer. It involves full thickness epidermal dysplasia, which spreads laterally without penetrating the basement membrane into the dermis. Similar to actinic keratosis, this lesion typically presents with erythema and scale. But on magnification, it has easily recognizable dotted vascular structures, often referred to as glomerular vessels. A diagnosis of in situ squamous cell cancer is often presumed to imply a significant risk of progression to invasive disease, leading to a high rate of surgical treatment. In fact, the risk of progression is exceedingly low, ranging from 3 to 5% for non-mucosal variants. The British Association of Dermatologists has issued guidelines specific to the treatment of in situ SCC, which emphasize its low-risk nature. The guidelines rank options based on various clinical factors, with the best choice at the top. 5-FU is recommended first line for small lesions at low-risk sites, large lesions on poor healing areas, and in immunocompromised patients. PDT is first line, and 5-FU is second line for large lesions at low-risk sites. Surgery is only considered first line for lesions involving challenging sites, such as the eyelids or nail unit. This is the patient from a few slides back, immediately after biopsy, followed by treatment with curettage. Here he is, a few months after completing an additional 4 weeks of topical 5-FU. If this lesion had been treated with surgery, it would have required a significant reconstruction. Here is another example. This lesion had been slowly increasing in size for years. It was treated with imicomod. This is the patient soon after completing treatment. Here he is a few years later. Keratoacanthoma is another lesion in the squamous cell carcinoma spectrum of uncertain but generally low risk. It presents as a painful, rapidly growing dome tumor with a central keratin plug. Multiple keratoacanthomas can sometimes appear eruptively with or without an obvious trigger. In some patients, keratoacanthoma can manifest the Kebner phenomenon and repeatedly occur in areas of skin irritation or trauma. Keratoacanthoma is usually treated surgically since it can be difficult to differentiate from a true invasive SCC. The patient from the previous slide presented a few months later with another lesion. Once again, it was excised. Here is a histologic image of a keratoacanthoma. Note how well circumscribed it is, and although it's quite thick, most of the tumor is projecting upward as opposed to invading down into the dermis. For those reasons, keratoacanthoma does well with narrow margin surgery. Electrodesiccation and curettage can also be a good option for treatment. In low risk but difficult to treat areas, particularly the anterior leg, there has been a recent shift towards intralesional methotrexate or 5-FU as first-line treatment. This patient was treated with methotrexate. Here's his lesion prior to his first injection. Here it is prior to his second injection. Here it is prior to his third and final injection. This is a few months later with only a small residual scar at the site of the tumor. Simple observation is also an option in some patients, since most keratoacanthomas eventually resolve spontaneously. In regard to invasive squamous cell cancer, the National Comprehensive Care Network has developed some of the most complete guidelines for risk stratification and treatment. Many of these lesions will require sampling of the deeper dermis for appropriate staging. Punch-based biopsy is often the better option, although in some cases, a deep shave will also be diagnostic. Cutaneous SCC does have a small but clinically relevant metastatic risk, so examination should include lymph node assessment, particularly for lesions on the head and neck. Low-risk SCC includes lesions under 2 centimeters on the torso and extremities that have well-defined borders and are not recurrent, are fairly well differentiated on histology, and that are not too deeply invasive. Treatment options for low-risk lesions include electrodesiccation and curettage, standard excision, or Mohs, and radiotherapy for non-surgical candidates. Primary treatment options are the same for high-risk lesions, apart from the removal of electrodesiccation and curettage. A common low-risk manifestation of squamous cell carcinoma is a shallow invasive focus at the base of a hypertrophic actinic keratosis. This patient presented with extensive AK on his scalp. One lesion was slightly larger and mildly tender on palpation. The image was taken after shave biopsy followed by electrodesiccation and curettage. Pathology was reported as early invasive SCC, clear of margins. 5-FU was then applied to the entire field. Here he is, a few months later, completely clear. He presented about a year later with a recurrence of his AK along with another prominent lesion. Same treatment. Here he is afterwards, clear again. Another presentation of SCC is of a well-defined, rapidly growing, painful whitish papule, often with some surrounding erythema. The white center of these lesions, which is due to the presence of underlying keratin, can be quite prominent, making them difficult to distinguish from a keratoacanthoma. Since their depth of invasion cannot be determined clinically, excision is the best treatment. They are usually reported as well-differentiated squamous cell carcinoma and are low risk. Occasionally, lesions that appear clinically low risk can turn out to have multiple high-risk features on histology. This tumor was excised with clear margins, but turned out to be only moderately differentiated. Moderately differentiated, deeply invasive, and contained an area of perineural involvement. Additional treatment was offered in the form of radiotherapy or wider excision with plastics. The patient chose a wider excision. SCC can also appear as a painful papule with scaly borders and a central area of ulceration. These lesions likely evolve from proliferating actinic keratosis. Associated risk varies based on size of the lesion and body location. Electrodesiccation and curettage is a good treatment option for small, low-risk lesions. This one was excised, since the ear is an area of higher metastatic risk. The same patient presented 6 months later with a similar but larger lesion on the opposite ear. I wasn't sure I could remove it with adequate margins using a linear closure, so I took a punch biopsy and referred him to plastics. Now he has a similar defect on both ears. The most concerning presentation of SCC is of a painful erythematous friable papule that bleeds easily. These lesions don't have much surface scale or white features on dermoscopy, since they consist of poorly differentiated keratinocytes that are no longer able to make keratin. This is a clinically high-risk SCC on the scalp of an elderly male. It was managed with a punch biopsy followed by referral to plastics. The same patient presented a few months later with a new lesion on the opposite side with similar high-risk features, same treatment. Here are some examples in skin of color. Small papule with a large central keratin plug, well differentiated, clinically low risk. Red friable papule with no surface scale, poorly differentiated, clinically high risk. Friable erythematous plaque in an old burn scar. This variant is often referred to as a Marjolin ulcer. They are always high risk. Keratotic papule on the cheek of an elderly female. Low risk appearance, but in a high risk location, excised with margins. Histology. First, let's look at keratoacanthoma again. It's very sharply defined, has a large amount of surface scale, and a mostly upward growth pattern. Here is a well-differentiated SCC. It is still quite well defined, still has a reasonable amount of surface scale, but you can see that a substantial portion of the lesion is growing downward into the dermis. There are large areas of pink stained keratin within the dermal component. That's what gives the lesion its whitish appearance. Poorly differentiated SCC. It doesn't have much surface scale or structure. It's just a disorganized mass of cells invading into the dermis. Last slide. A reminder that metastatic disease is a legitimate concern in the context of SCC. Clinically mild actinic keratosis, similar to the patient in the slide series I showed earlier. Treated with 5-FU calcipotriol with near complete clearance. The patient developed a high-risk SCC a few years later and failed multiple treatments. He went on to develop extensive local regional metastatic disease. Summary, basal cell carcinoma, most common human malignancy, very low risk for metastatic disease. Superficial and nodular variants are low risk for recurrence, can be identified on a clinical basis. Shave biopsy is often adequate, many treatment options. Infiltrative variants are at higher risk for recurrence, require deeper biopsy for adequate diagnosis, do best with standard excision or Mohs. Actinic keratosis has two major growth patterns, upward into the epidermis and downward into the dermis. Upward growth generates the most clinically obvious keratotic lesions, but they are often not the site of progression to squamous cell carcinoma. Risk reduction requires treatment of the entire area of involved skin, not just the obvious lesions. Squamous cell carcinoma, in situ SCC has a very low rate of progression to invasive disease, best treated with non-surgical modalities. Keratoacanthoma looks clinically like well-differentiated SCC, but behaves differently. Low malignant potential, historically managed with excision, but more recent shift towards intralesional treatment. True invasive SCC does have a small metastatic risk. In many cases, it requires deeper biopsy for appropriate diagnosis. Treatment is predominantly surgical. These were our objectives. Hopefully, we've achieved some of them. Keratinocyte cancer is a very broad topic, difficult to cover in 45 minutes. I had to leave quite a bit out that I would have liked to include, but I'm happy to go into greater detail during the Q&A. Before we start, I just want to point out that our website has a section with resources for healthcare providers. So that's the link at the top. You can find many patient handouts there that we put together. You'll also find a link there to our YouTube page where there's some videos on skin conditions. And then I've also put in a couple links on some skin cancer related podcasts that I've done for something called GP Insights, which is put on by an organization called HealthCert. One is on FUDEX with calcipotriol for AK, and the other is imiquimod for BCC. All right, I'm going to turn the lights on in here too, just a second. There we go. All right, Chris, are you going to hit me with questions?
You bet. Yeah. Thanks, Gene. That was amazing. So much information. I really actually enjoyed the basic science. I kind of miss that, and it helps provide context. So that was great. We have one question that's been voted up to the top, and that is,
Okay.
please describe the procedure of superficial shave biopsy.
So shave biopsy?
Yeah.
Okay. So in most cases, you're using basically a razor blade of some kind. There's a commercial product, or you can use just a razor blade that you can, purchase online essentially and sterilize. We use a one-sided blade, so it doesn't have a sharp blade on either side. It's bendable in the middle, which is what defines your depth. Usually you will want to, first, anesthetic, mark the lesion before you anesthetize, because superficial BCC, you're relying on the erythema to identify the lesion. A lot of it is going to disappear. So mark the borders of the lesion prior to anesthetic. And then when you do the procedure, you want to use your surface disinfectant as a lubricant. So you disinfect the surface, prep your tray, give yourself some time, and then wet the surface again just before you apply your blade to the skin surface. And then you're basically bending the blade and you're moving the blade back and forth. It's like a sawing motion through the skin. Your goal is to get into the superficial dermis. So because you're diagnosing epidermal lesions, you don't have to go all the way through the skin. You just need to make sure all of the epidermis is in there. So you want to get into the superficial dermis, and the way that you know you have is you will see small areas of pinpoint bleeding on the skin surface. That's from the dermal papillae. So when you wipe it with your gauze, you wipe the blood away, and then a bunch of red dots will appear, and then wipe it again and they'll appear again. And you can gauge your depth. So if you're over time, as you do more of these, you'll just adjust your depth until you're seeing that result every time.
Awesome. Great. Thanks, Gene. So we're going to follow up with a question that's similar, procedurally related. Can you please explain how you do electrodesiccation and curettage? Do you routinely do this for lesions that you suspect will come back as BCC and SCC?
Yeah, great question. So electrodesiccation and curettage is two different modalities of treatment together. So the first step with an EDC is usually a shave biopsy. You may do that biopsy at the time of the procedure, or you may do it beforehand. So if you don't know the diagnosis, you're not sure, you may just take a shave biopsy and wait and see what it gets reported as. If you're confident that you're looking at a low-risk lesion, you can take the shave biopsy. The next step is going to be curettage. And for those who are not familiar, curettes it's like a round blade. It's got a little handle and a circular blade at the end. One side is sharp, the other is not. There are two variants out there. There's a disposable one, and then there's like a true autoclavable steel instrument. We do not use the disposable one for curettage. The disposable one is basically a razor blade in a circular orientation. It cuts, it doesn't scrape. So the disposable one is good for taking biopsies in nooks and crannies like the ear and next to the eye. The tool you need for curettage for treatment is the actual metal instrument, because you don't want it to be overly sharp. And the curette, there's a kind of a three-pronged element to it. You can see what you're doing. You can see as you scrape the lesion away. You can feel it in your hands. There's like a vibratory kind of feel to it. And there's a sound to it. There's like a scraping sound that disappears as you get down onto the dermis. The most common lesions for this are going to be superficial BCC and in situ squamous cell cancer. And what you're relying on is the fact that they have abnormal desmosomes. So the abnormal keratinocytes are not adhering to each other normally. But once you get out to the edges of the lesion where there's normal skin, you'll stop lifting the cells off the surface. You're also relying on the fact that once you get down to the dermis, you're just sliding the blade along a smooth dermis. The electrodesiccation component is it's a second component that you may or may not add. So you'll notice I purposely put in one case, the lady with the basal cell cancer on her nose, where I did not use electrodesiccation. I just curetted. There's a series of papers that show that that's actually quite effective. What it comes down to is, what is the balance? Do you want cure, or do you want the best possible cosmetic outcome? Electrodesiccation will bump your level of cure up, but you might get more scarring. So if you're dealing with a less cosmetically important area on the back or something, you're going to want to use electrodesiccation. But if you're on the nose or the forehead or somewhere like that, you may just do curettage. Electrodesiccation is a wall-based unit called an electrosurgical generator. And you're basically just dialing up the level. You want a fairly low level for what you would do with skin cancer. We have 40-watt electrosurgical generators. I usually do 4.5 or 5, so about an eighth of the maximum setting. And you're running it over the lesion after you finish curetting. It's like filling in something with a pencil. You're just sort of running it over the surface. It'll stop the bleeding, but it also triggers an inflammatory response. So you get an immune response after the procedure, and that's basically mopping up any residual tumor that you haven't cleared physically by curettage. I always warn patients after the procedure, they're going to have a little red halo around the site, and that's that inflammatory response, so they don't get worried that they've got an infection. Some of these get infected. In that case, it'll be erythema spreading, beyond the margins of the wound. But if it's a tight red band around the wound, that's normal and expected.
Thanks, Gene. Awesome answer. Great. We're going to move to the chemical treatment a little bit. So can you explain the use of calcipotriol with 5-FU? What is the benefit compared to 5-FU alone?
Yes, yeah.
And then also, we have another question. What's the recommended duration of treatment for FUDEX or both?
Yeah. So there's a group out of Harvard that looked into calcipotriol with 5-FU. If anybody who's interested, I would go to our website, to the healthcare provider resources. We have a patient handout on how to use 5-FU with calcipotriol. It walks them through it all, but it also has links to the studies that were done with it. Calcipotriol on its own triggers something called thymic stromal lymphopoietin. It's a master immune regulator within the skin. And so the early trials for using it for skin cancer, they were looking at just calcipotriol on its own, and it didn't work. But when they combined it with 5-FU, they got the effect they want. And the theory out there is that the 5-FU is actually acting more as just an irritant, like a skin irritant, allowing the calcipotriol to penetrate deeper. So I often tell patients that we're relying on chemotherapy and the calcipotriol makes it faster. But in reality, it's actually the calcipotriol that may be doing much of the work, and the 5-FU is just sort of helping it do its thing. So this is like the combination of the two is one of these examples. We often hear about repurposing old drugs. So two old drugs, one's 60 years old, the other's 40 years old. You put them together and you end up with a different mechanism of action, but with a similar effect. So, and the time on the face, the studies that were done, they used 4 days on all body areas. And they got a clearance rate that was similar to doing 2 weeks of 5-FU. Our clinical experience with it in hundreds of patients, I would say it's our #1 field treatment now, is that 5 days works on the face for many patients, but 5 days is not enough on other body areas where you have thicker skin. And that's the experience, most providers have used just 5-FU on its own. They're very familiar with that, where it might take 2 weeks on the face, and it might take 3 weeks on the scalp and 4 weeks on the arms, or, as skin thickness increases. So the same thing happens with 5-FU calcipotriol. We recommend starting with 4 days on the face. The patient gets a sense of how sensitive they are to it. And if they've got a kind of an average sensitivity, they'll get a good effect with about 6 days on their scalp and neck, and they'll need about 7 to 10 days on their arms or legs.
Great. Thanks, Gene. Dr. Naismith wants to ask about histology of Ka versus SCC. David, did you want to articulate your question a bit?
Can you hear
Maybe
us?
he, no, I'm not sure. Maybe he had to
Okay,
sign out.
can you hear me now?
Yeah, I gotcha.
Okay.
Okay, great. So my experience in speaking with patients is that I would always tell them if they had something that looked like a KA and I was trying to distinguish that between a squamous cell, I usually differentiated based upon the growth, the rapidity of the growth. And I always used to tell patients, you know, we're going to send this to pathology, but the pathologist is not going to give us the definitive answer. I got the sense from when you were discussing histology of KAs that this was a very clear cut, you know, no downward growth, everything outward. But I still find today that pathologists will always hedge and say, you know, this looks like a keratoacanthoma, but we cannot rule out squamous cell carcinoma. So I might ask you to just address that. Because that's going to be a problem with anybody who deals with these things, because they're going to get that response back from the pathologist. The other thing I want to say is both those lesions that you showed on the ear, you know, it looked like each of them had been fighting with Mike Tyson, and it had a piece taken out. You know, if you use a helical rim flap with a Burroughs triangle in the lobule, you can take out up to about 1.5 centimeters to 2 centimeters full thickness of the helix and still close that and make it look like a perfectly normal ear. So just that's just a comment, but I'd be interested in your thoughts on histology. Thank you.
Yeah, I mean, I can address, I guess, both. So first off, on keratoacanthoma, it depends on a few factors. The first is, are you sending the entire lesion or are you sending a small sample, right? Because if you're doing a punch into a keratoacanthoma, you're always going to get a diagnosis of SCC, because histologic diagnosis, it depends on cytology, but it also depends on architecture. And so if the pathologist can't see the entire lesion, they're going to have a hard time making a diagnosis, and they're just going to call it SCC. You could, in theory, do a incisional biopsy where you just take an ellipse through the center of a lesion, so the entire architecture is presented to the pathologist. It's usually not worth it. It'll be a mess. You might as well either excise it or do something else. The other thing, it depends on who's reading the actual slides too, whether you have a general pathologist or you have a dermatopathologist. So the dermatopathologist, they love to get into the weeds on, is it a keratoacanthoma, is it not? I know there are specific features they will look for to where the weight of the evidence is this is a true keratoacanthoma or SCC with keratoacanthoma features and things like that. Just getting to the clinical piece too about how these lesions progress. The problem with these lesions is that you don't know when you see that patient early on and this thing is rapidly growing, whether this is going to turn out to be an SCC that looks like a KA and it's just going to keep growing and get uglier, or if it's going to stabilize and then eventually involute like KAs do. And then the final thing with KA too, if you just leave it to involute, sometimes there's quite a scar left behind. So surgery sometimes is still a better option. In regards to the ear, I agree completely. There's a lot of options. My practice doesn't involve reconstruction. I know I work closely with the plastic surgeons here in town. So if I can take it out with a fairly straightforward procedure, great. And if I can't, I've got this great team of plastic surgeons I can forward the patient on to.
Thanks so much. Okay, I got to ask this question because I don't know what it means. So can you comment on the different types of PDT?
Oh, yeah, sure. That is a good question. Yeah, I mean, there's basically two major variants. There's daylight photodynamic therapy, and then there's more than two, but in skin cancer, there are predominantly two variants. There's daylight photodynamic therapy and red light photodynamic therapy. It comes down to which light source are you using to activate your photosensitizer. So photodynamic therapy involves topical photosensitizer. It's just an amino acid. But it turns into a photosensitizer in the skin. So you apply the cream to the skin, and then you're going to need to activate it somehow. You can use natural daylight, which has a range of light spectra in it. So the compound has very specific spectra that will activate it. But because natural daylight has the whole spectrum, you can use it. The problem is it just takes a long time. but it also means that it's often less painful. When used in clinic, PDT is usually used with a specific spectrum of light. 630 nanometers is the red light that's most often used. It was designed for the convenience of a clinician, so the whole thing takes about 8.5 minutes. But it can often be quite painful. Some patients who do PDT, they come out of it saying, I'll never do that again. There's sort of a tingly skin discomfort that occurs in some patients that can be hard to mitigate. So that's sort of the spectrum for actinic keratosis. Once you get into treating cancer, if you're treating basal cell cancer, daylight illumination is generally not used. So you're in a clinic scenario and you're usually relying on a red light. And then the final bit with PDT, there's a blue light that can be used for actinic keratosis. I don't use it in my practice. I think some providers do. And it's also used for other indications.
Great. Okay, we got 3 more questions. I think we're going to be able to knock them all off in the next couple of minutes. So someone asked, some of your photos appear scaly, but you say that it is not scale. Could you please elaborate?
Yeah, so that's the reason I put the, so first off, there's going to be some scale on many of these lesions because they are epidermal in origin. They're coming from keratinocytes, and that's what keratinocytes do, is they form scale. There's also going to be what we often refer to as collision lesions. So many people who have a basal cell cancer on their face, they also have actinic keratosis on their face, and so you're going to find a little, a pearly bump, but it'll be surrounded by scale because they have 2 processes at play. But it's important to understand that the reason we have 2 categories, basal cell cancer and squamous cell cancer, is because the site of origin of these lesions is very different. And so it manifests itself very differently. When you're coming from the basal layer, those keratinocytes are keratinocytes that are multiplying. They are not, they're not moving up through the epidermis and becoming keratin. As soon as any lesion that's coming from higher in the epidermis, it's going to be keratinizing cells, and it's going to start to form scale. The other thing, I tried to emphasize the crust versus scale because they look the same. I had some very dramatic photos, but I took them out because there's just too much. But it can be really like you look at something and think, oh my goodness. And then as soon as you start to wipe it with a piece of gauze, soaked with alcohol, you realize it's all coming off the surface of the skin because it's all crust. And underneath it will be something that is oozing, it's bleeding. That'll be your basal cell cancer or whatever it is. Keratin scale is quite adherent to the surface of the skin. So if you wipe an actinic keratosis, eventually you'll lift some stuff and you'll probably get a little bit of bleeding or something. But mostly you'll be wiping it and it will stay on the surface.
Great. Thanks, Gene. Okay. Tips on how to apply imiquimod, please. Or imiquimod, as you say.
Okay. So again, if you go into our healthcare providers resources, we have a very detailed 2-page handout for patients. And I also go into it in the podcast. There's a couple ways of doing imiquimod, basically. So there's a standard approved way, and I should comment, imiquimod is approved for superficial basal cell cancer in North America, but it's approved for nodular basal cell cancer in other jurisdictions. So if you look at Europe, some countries in Europe approve it for that as well. And if you actually do a dive into the data, the results are pretty good for small nodular basal cell cancers. So, I'll cross over and I'll do superficial, but I'll do nodular as well. The way it was approved is 5 days a week for 6 weeks, just a cookie cutter. Everybody does the same thing. The issue with imiquimod, and this is similar with 5-FU calcipotriol, as soon as you're using an immunomodulator, you're going to start seeing a range of response to the compound. And you have to expect that. So if you just put everybody on the same treatment, you're going to have some patients who are going to, they're not going to tolerate it. They're going to have a very intense response within a couple of weeks. They're going to have tons of erythema, crusting, or they might have systemic symptoms and they're just going to hate it. And you're going to have people at the other end of the spectrum who are not going to get the effect you want. You're not going to get an inflammatory response, or at least not a sufficient one to clear the lesion. So what we do is we start slow, usually 3 times a week, Monday, Wednesday, and Friday. And then we increase the dose every couple of weeks. So you do that for 2 weeks. Then if you're not getting much inflammatory reaction, you go up to 5 times a week. If you're not getting much inflammatory reaction, you go up to once a day, and then eventually you go up to twice a day. And in theory, you could also, start putting dressings on or something, and you might augment the response that way. Usually while patients are on it, I will do a virtual appointment with them about every 4 weeks. They get a link with information on taking photographs. So we just do some photo sharing. I take a look at how things are coming along, and then I'll guide them a little bit on how to adjust the treatment. We often go beyond 6 weeks. I treat to an end point, not a time thing. So I'm looking for an inflammatory response. I want to sustain that, but keep it tolerable for the patient. And then I want to see that inflammatory response start to fade. That's telling you that their immune response is now settling down. They have cleared the tumor. And so I tell patients 6 weeks is a minimum, but up to about 12 weeks is usually where we go. We also use imiquimod for lentigo maligna, and sometimes there we're going even longer.
Thanks, Gene. Okay, last question. Thanks for hanging in there. We appreciate it. You're doing a great job. How can one get trained for dermoscopy? What's the best way to approach that?
That's a great question. My standard recommendation for dermoscopy is to do a course through HealthCert. I'm biased because I think in your intro there, you mentioned I was a medical director for their first Canadian skin cancer procedures course. But they've done a great job. It's easy to sign up. It's online. I don't know how long it is off the top of my head. It's several stages. I think they have a basic, intermediate, advanced sort of program. My gut feeling is it's probably about 4 months for each one. The instructors are the best people in the world. Everybody who is publishing in that area is teaching their course, and they've got a great textbook as part of it. And it's something that many providers, in primary care, you can do it longitudinally, in your free time.
Awesome. Thanks, Gene. Okay, that comes to the end of today. Thanks everybody for staying a little bit later. And just a huge thank you to Gene for such a action-packed talk with so much information and great question answering. If anybody has any burning questions, you can always reach out to us and we can filter them to Gene. Or I think, Gene, do you have a contact there?
I'm not sure that I do, actually, but if they forward questions to you, I'm sure I will.
Yeah,
receive them from the,
we'll do that. And we'll have the recording available for people. And then in addition, we're going to send you an evaluation. If you could fill that out, that would be great. It helps us make this better and continue to move forward. And with that, we'll call it a wrap.
Thank you, everyone.
Thanks, everybody.